welcome to this BTOG podcast. My name is Emma O'Dowd and I'm a respiratory physician from Nottingham and also a member of the BTOG steering committee. And this is a part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their field and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers. It's also important to say that the sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything discussed. Today's podcast is BTOG Does Tobacco Dependency in Lung Cancer, and it's a pleasure to introduce Professor Sanjay Agrawal. Sanjay is a respiratory physician from Leicester, but is also the current National Specialty Advisor for Tobacco Dependency at NHS England, and also the Specialty Advisor on Tobacco to the Royal College of Physicians. So welcome, Sanjay, and thank you for giving up your time to talk about a topic that I think is something that over the years that I've known you, you've been incredibly passionate about. So I thought we'd start by maybe just covering just briefly what the scale of the problem is at the moment in the UK.
Yeah, thanks, Emma, and thanks for inviting me on. But actually, before I do that, can I just mention a couple of things? So firstly, I've just come from my lung cancer clinic, and my interest in this topic area came about, 20, 25 years ago when I first started doing lung cancer clinics. And my observation at the time was, it was really sad that I was seeing all these people with new diagnosis of lung cancer coming to my clinic every week. And we also knew, and still do know, that smoking is the biggest single cause of lung cancer and many other cancers, but lung cancer specifically. And so I asked myself the question, so what are we doing about treating tobacco addiction so that these folk didn't actually ever get lung cancer to begin with? And I asked one of my friends who's a consultant in the clinic at the same time, and I said, yeah, so what are we doing? How are we treating this? I was new to Leicester at the time. And he said, Sanjay, that's not our job. That's a job of public health. Okay, that's a bit strange, all right. And so I asked my public health colleagues who I happen to know, and I said, what are you doing about these people who smoke, who come into the hospital? What are we doing about treating tobacco dependency? And they said, well, that's not our job, Sanjay, that's your job. They come in to see you. So, it became very clear to me that actually nobody was doing anything. And it felt pretty terrible that as a health service, we were sort of letting it go by, almost just ignoring the fact that we could intervene and do something that would prevent not only lung cancer, but 15 other cancers, strokes, heart attacks, aneurysm, dissection. And just this morning, for example, again, I was on our intensive care unit, and I saw people who've had heart attacks in the last few days. I had a couple of people who've had aortic dissections recently, and all of these are supremely preventable. So my interest in the topic area came from the fact that we weren't doing anything about it in the health service, even though smoking is the single biggest cause of preventable illness in our country. We weren't recording people who smoke. We weren't treating people who smoke. And that's just a ridiculous situation. So,
and I think we still have that issue in terms of recording, don't we? We know that, there's always a plea from the National Lung Cancer Audit Team, please, can you record what proportion of your patients are current smokers, ex-smokers, because those granular data are still not really available to us. And I think that, there is still massive variability in how well we still do treat people who have lung cancer and think of tobacco dependency as something that is there to be treated, not just a lifestyle choice.
That's right.
Imaging, yeah.
So we treat. So what we do, and where it is recorded, it's often just recorded as a risk factor, as opposed to something I must do something about. So it would be unfathomable that somebody came into hospital and you recorded, oh, they have pneumonia, and then you didn't treat the pneumonia, or they come to hospital with a heart attack and you didn't treat the heart attack. But for some reason, when people come into hospital anyway, or some of our clinics, and they smoke, we kind of just write it down and then ignore the fact that we've just written it down instead of trying to address it. So that's what tweaked my interest. And I think the other thing for our listeners, Emma, that I think we should declare a conflict of interest is that Emma and I were both involved in writing questions for the Royal College of Physicians. Me a few years ago, I think Emma still does that. And so I infiltrated the question writing group simply to put some questions in about tobacco, because one of the things I know is that oftentimes, certainly medics, they do question, they revise for exams based on whether they're going to or they learn stuff based on whether they're going to be examined on it. So my grand plan, my master plan, was to put some questions in so that people were asked how to treat tobacco dependency, so that hopefully they did it. And I think Emma, you probably continued that
Yeah, I
objective.
think it's another reflection, isn't it, that it's something that's actually taught very badly. It's not necessarily taught through medical school. We don't get training and throughout your kind of SHO, as was type training on just simple things like that, to be honest. So I think it is still something that is a bit of a black hole.
Yeah, and one of my reflections is one of the reasons that as doctors we don't treat tobacco dependency in our clinics or in our hospitals, whether you're an oncologist or a respiratory physician or an intensivist, is because we were never taught how to. And we were never taught how to, and we were never examined on it. And therefore, it was a nice to learn thing rather than have to learn thing. But getting back to the beginning of where we wanted to start, I think, today, Emma. So, look, the scale of the problem is it's still nuts. There are 6 million people who currently smoke in the UK. Again, if I said to you there were 6 million people who had COVID in the UK today, that would make you raise your eyebrows, or 6 million people who had flu today, because flu and COVID are lethal conditions. Well, more than 2 in 3 people will die of smoking, and 6 million people smoke. But it doesn't quite we get desensitized after a while to large numbers, I think, associated with smoking. But in the UK, it accounts for about 70,000 deaths. About a quarter of all cancer deaths are due to smoking. But one of the problems we have in lung cancer anyway is that we have a lot of smoking related disease. So people may not if you like, develop lung cancer, but they might develop coronary artery disease or stroke or whatever. And it's those comorbidities that might stop them from being treated for their lung cancer or their esophageal cancer or their pancreatic cancer. So for every person that dies of lung cancer, 30 develop comorbidities where it impacts their quality of life and therefore other treatments. And so that's a travesty. But globally, would you believe, Emma, I'm going to ask you the question. How many people do you think smoke around the globe today?
Oh my goodness, putting me on the spot now.
Pick a large number.
I actually have no idea. Am I going to go for a billion plus?
So it's 1.2 billion people. 1.2 billion people do a pointless thing of burning tobacco and then inhaling the smoke. And actually, 80% of those people are in low and middle income countries. So those who can least afford it do it. And that's driven by the tobacco industry, who will sell tobacco to anybody. So that's a big problem. So it's a problem globally. And actually, in terms of numbers of people smoking, there are more people who smoke on the planet today than there were 30 years ago, because the population's increased and there are more and more sales in those lower middle income countries. In the developed world, smoking rates have come down, but they're still massive.
I saw something that was slightly concerning as well, was that actually our highest smoking rates in the UK are actually in the younger age group at the moment, which you presume that we have lots of people who started smoking years ago and still smoke, but we still have a not insubstantial group of people that are starting smoking as well, which seemed a bit concerning when I was just looking at some stats recently.
Yeah, so actually that's usually a pattern. There's some good news there in a minute. So traditionally, if you think about it, most people probably tried smoking when they were younger, me included, or at university or whenever. And the problem is a lot of those people then continue. And when you're young, you're immortal, aren't you? You're not worried about things like that. You don't worry about your future. So it's not unusual that young people have the highest prevalence of smoking. But then a proportion of them just carry on and never stop because it's highly addictive. But the good news is the tobacco in vapes bill in future will address those young people who are experimenting and then start and then get hooked, because the Tobacco and Vapes Bill, which I'm hoping will come into law either later this year or early next year, will mean that anybody born after the 1st of January 2009 will never legally be able to buy tobacco. And the age of sale of smoking will go up by 1 year every year. So that will be good in terms of stopping young people being able to buy tobacco. And it will mean that the prevalence of smoking will go down in those younger age groups, which will eventually mean that there'll be nobody who's started smoking in the UK in theory will continue to smoke. Obviously, there'll be illicit tobacco that people get a hold of. So that's really good news. So stopping the start is what the government called it, the tobacco and vapes, which is great.
And are you optimistic that this will actually go through? I think is it in the Lords? It's gone through Parliament, is that right? At the moment,
yeah.
It's in the Lords.
So the process of that is that it goes through the House of Commons first. It's been through that stage. It now goes to the Lords. It's in the Lords now. They'll debate it, amend it potentially, send it back to the Commons. The Commons then will either agree to the amendments or not. And then likely it'll pass into law later this year, which is great news for the UK. It'll be a first. No other countries.
Yeah, New Zealand almost got there, didn't they? And then they had a new government, and that's always the worry, isn't it? That something changes with a new government.
It is, but the good news is this has gotten cross-party support. So if you remember, actually, it was a Conservative government that introduced the bill, and then we had a change of government, and the Labour government have now taken on the bill too. So it's likely that it will come in because it has good, strong cross-party support. The downside of it's not really downside, but the unaddressed question is the 6 million people who continue to smoke. So the Tobacco and Vapes Bill will do nothing to get them to stop smoking. It's all about stopping the start. But there are other things that we can do, and maybe we'll talk about that in a little while. The other thing I just wanted to just mention as well is health inequality. So one of the things that often happens, and I'm a little bit worried about, is that the government might say with the Tobacco and Vapes Bill, look, the job's done. We don't need to do anything else. But actually, if you look at prevalence of smoking, whilst it's coming down for the general population as an average, if you start looking at protected characteristics and certain populations, actually, the prevalence of smoking is really high. So, for example, in professional workers, prevalence of smoking is less than 10%, probably 7 or 8%, whereas in routine and manual workers, it's 20%. In people with mental health disorder, schizophrenia, it's 40%. In the unemployed, it's 30 to 40%. In those who are homeless, it's 80%. So you don't have to look very far. And actually, the problem of smoking is highest in those who can least afford it. Literally, those who can least afford it. And the reason they do it is not because, they don't understand it's harmful. It's because they're addicted to nicotine. And one of the light bulb moments for me, Emma, was when I realized that tobacco was an addiction. It wasn't a free choice. And the addiction starts early when you're young, and then you're bombarded, usually because of tobacco industry tactics, with people who smoke in music videos, in gaming videos, on Netflix. Everywhere you look, there's a reminder, and these days with social media too. So it's not unlike the gambling industry. So if you look at Premier League football and lots of other advertising, there's loads of gambling advertising, and there's a huge gambling problem in the UK now. Ditto alcohol. But that's why the industry perpetuate the addiction. And the chief medical officer, Chris Whitty, has also made the point that smoking is not a free choice at all. It's an addiction. And it was that light bulb moment that made me realise that actually I needed to treat the addiction by providing NRT or providing drugs that counteract the addiction, like, for example, cytosine and varenicline. So, Emma, I'm going to ask you a question now. Do you drink coffee or tea?
Yes, both.
How many cups a day do you get through?
Roughly 2, 3.
2, 3. Have you ever just stopped altogether?
Well, and get my withdrawal headache, you mean,
Yeah,
from my coffee? Yes. So
yeah,
occasionally, yes.
yeah. So have I. So I tried it once. We were doing a clinical trial, and one of the entry criteria was not having caffeine for a month. And I thought, I'll give that a go. And it was the most awful thing I've ever done. It was stopping drinking tea or coffee, and it brought home the issue of addiction. And in the end, I had to drink a cup of hot water in the morning because I just missed the ritual of having a cup in my hand and do. So, but the point I'm trying to make is that we're all addicted to something, and for a lot of people, that's nicotine. And it doesn't take much when you try and stop doing something to then unfortunately fall back into it. And because of the addiction, it takes people sometimes 20 or 30 times to quit successfully, before they fully quit. And as doctors, we need to just recognize that. Now, addiction physicians are really well trained. So, like methadone programs for heroin, or needle exchange programs for HIV. The concept of addiction and harm reduction and switching is very common, but we are not trained as addiction physicians. So we don't really know how to treat addiction. But the good news is with tobacco, we've got some great treatments. We've got NRT, we've got cytosine, we've got varenicline, together with behavioural support, and actually they're really successful at treating addiction.
And I think that's probably a good sort of segue in, Sanjay, to talk about some of the newer treatments. Obviously, lots of us are very familiar with NRT. We're perhaps less good at the different delivery devices because I think we forget how good a cigarette is at delivering the nicotine, and we are using things that are probably less good, particularly if we don't use them effectively as well. And that's often what people struggle with. But then we also have the sort of the new kid on the block of cytosine, which is not new to many countries, and also varenicline coming back, which I think means that we now have a lot of drugs, but people are less familiar with them. And I think, as you say, it's about teaching people. So I wonder if you could give us a bit of a snapshot into the best ways, because often it's a multitude of different things that we need to give all at once, isn't it? Not necessarily just one delivery
Yeah.
device.
So that's absolutely right. So look, if somebody said to me, Sanjay, could you prescribe this new drug for diabetes or hypertension that I'd never prescribed before? I find it really difficult because I'm not familiar with it. I don't know the side effects. I don't know the dosage, what to warn patients about. So it's completely understandable. But what I would say is that thankfully, you can't go wrong with smoking cessation treatment. So, for example, with nicotine, there's two big things you have to remember about prescribing nicotine. Firstly, you must do it when people come into hospital, for example, because it stops horrible withdrawal symptoms. And you use together a long acting nicotine, so like a patch. And I just remember 21 milligrams in 24 hours. So a 24-hour patch. Um, and then you give a short-acting nicotine, which kind of behaves like a cigarette. So that that quick puff that people have when they light up a cigarette, that's what you're getting from the short-acting nicotine. So there are different forms of short-acting nicotine. You can have gum, you can have lozenges, you can have strips that go just under your tongue. There are mouth sprays, and it's just a matter of becoming familiar with one or two that then you always prescribe. You don't have to become familiar with all of them. So for me, I always remember the nicotine lozenge, which is in 2 milligram dosages, and you can take it up to 8 times a day. And I remember a 21 milligram patch, which you give over 24 hours. There are other sizes, but just become familiar with one. There's not really a right or a wrong. You can't overdose with nicotine replacement. So a long and short acting, just become familiar with one dose. With cytosine, the way that works, it works in the same way as varenicline. They're both what we call dual nicotine antagonists and agonists. So they mimic nicotine. They make the brain think it's getting nicotine, and they sit on the nicotine receptor in the brain. So the brain feels satisfied that it's got something, and there's a small release of dopamine, which is what nicotine does at these receptors. So there's a bit of satisfaction too. And it also means that when somebody smokes on top of taking the drug, they get no satisfaction. So you break the positive feedback loop from smoking because there's no satisfaction from smoking. So that it's a terrific drug, very clever. And with cytosine, It's really easy to prescribe. It's a 25-day course. So, if you think about it, it's like, I don't know, a very extended course of an antibiotic, 25 days, and you're done with this lifetime addiction. It's fantastic. And essentially, you use a reducing dose. So a bit like as a lung doctor, I prescribe prednisolone in a reducing dose. I drop the number of pills by, one or two every couple of days. Cytozine's much the same. You start off with 6 pills a day, then you reduce down to 5, and then 4, and then 3, and then 2 over 25 days. So that's dead easy, I think. The tablets are 1.5 milligrams. When you prescribe it, you just prescribe a 25-day course. And then varenicline is the other drug. It used to be called Champix, but now there's a generic version. And with that tablet, again, it's really easy. You take it twice a day. For the first week, though, you just titrate it up. So you take a 0.5 milligram for the first 3 days, once a day, and then 0.5 milligram twice a day, days 4 to 7. And thereafter, it's 1 milligram twice a day for 12 weeks, though. So it's a longer course. Both of these tablets work even better if you give NRT, especially in the first week or two. Dead easy. And you could cure a lifetime of tobacco and prevent numerous diseases just by literally a simple prescription of NRT or cytosine or varenicline. It's amazing. And actually, in our outpatient clinics, we can prescribe it when we're prescribing other drugs that we might be prescribing. So, we might be giving out antibiotics for something. We might be giving out, like I did this afternoon, some pain relief for somebody with lung cancer. We can just give these drugs. And actually, what's really interesting is patients expect you to talk to them about smoking. It's us as doctors or nurses that are actually uncomfortable because we don't know how to treat it or we don't know what to say.
Yeah. And I think the only caveat for our lung cancer population is the age cutoff for cytosine, which sadly is not licensed for those over 65, is it?
That's right, and so that's why varenicline is easily substituted for that reason.
And I think if we move on to our lung cancer population, I think there's some really great recent data, I think, from studies showing exactly why we should be viewing this not as something that is optional to treat, but actually an essential part of your lung cancer treatment. And I think one of the studies that I was going to ask you to mention was one that was published in JAMA Oncology recently from the group at MD Anderson, who do some amazing work actually looking at treatment of tobacco dependency, but a really amazing study in people with all types of cancer, actually, not just lung cancer.
Yeah, I thought that was a terrific study too. So, look, all of us will have patients, or even might think it ourselves. You've got somebody in front of you who's got a cancer. What's the point, quote unquote, of talking about stopping smoking? And that sadly kind of old-fashioned nihilistic approach, may still be prevalent in some places. So what MD Anderson did is they looked at their data going back a couple of decades, and they looked at the patients who had started on smoking cessation treatment, and then they followed those patients up over a period of 15 years using their cancer registry, which they have. And what they found is that people who quit smoking within 3, 6, and 9 months of their cancer diagnosis had a improvement in their survival over a 15-year period. The best stats were people who stopped smoking within 3 to 6 months of their cancer diagnosis. But even people who stopped 9 months after their cancer diagnosis still had a benefit. And that was a benefit based on either the tolerance of treatment, presumably, and the treatment of their original cancer. But it also, presumably, a lot of the benefit will have been a reduction in other smoking-related diseases that may cause death, such as heart disease, stroke, etc., and also secondary cancers. So we know that stopping smoking even after a cancer diagnosis has benefits. And in the lung cancer world, of course, we have this concept of survivorship, right? So we treat people with cancer, hopefully we cure them, but we know that we also need to support people to think about other things that will improve their longevity. And one of them is smoking, and that's what we're talking about today, but it may also be hypertension control, it might be cholesterol. It's all of these things that will improve the survivorship of our patients. And so I think that particular study was terrific. But what's also interesting, over the last few years, I think the field of lung cancer has become so interesting in that we've now got lung cancer screening. We've got the optimal lung cancer pathway, which starts with triage and then goes into lung cancer clinics. We then got the sort of treatment pathways for our oncologists and our surgeons and our radiotherapists, and we've got the concept of survivorship. Now, you can insert the treatment tobacco dependency at all of these different time points. And there have been a couple of terrific studies from the UK looking at lung cancer screening and optimizing treatment of tobacco dependency during our lung cancer screening program. Now, Emma, you will know more about this, so please correct me if I'm wrong. But my understanding is the National Screening Committee had approved lung cancer screening in the UK last year before, and the potential benefit is to about 4 or 5 million people who meet the criteria of being between 55 and 74, smokers or ex-smokers, and COPD. And of those 5 million people, roughly 20% of them will smoke, be current smokers probably. So that's around 1 million people. And there was a trial that Rachel Murray led, who's in at the University of Nottingham, called the Yorkshire Enhanced Smoking. What's the second S
Stop
stand
smoking
for?
study, yeah.
STEM study. There you go. The S study, which is a great title, I think, for study. And what they did in that study was really interesting. Firstly, they identified people who smoke, and then on an opt-out basis, essentially treated everybody for tobacco dependency. So everybody enrolled in the study were treated with high quality treatment. They were seen by a tobacco dependency advisor and given behavioral support for 4 weeks and pharmacotherapy. That was in both groups. And the intervention group also got a booklet showing them pictures of their lungs to, I suppose, see if that would encourage them to quit even more, be even more motivated. But what they found in both study groups was a minimum quit rate of 30% that persisted at 12 months, which is amazing because these are people who came into the program not intending to quit smoking, and a third of them almost quit smoking. The enhanced bit with the booklet helped a little bit, and it was particularly pronounced in women who were part of the screening program. But I think the point of that study was, for me anyway, is that if you treat tobacco on an opt-out basis where it's just routinely treated, you don't have to wait to ask for people. You don't ask people if they'd like to be treated. You just treat them like you would pneumonia or something else. You just treat them. Most people will take you up on it, and there's a really high success rate, which is just terrific. So some of those people won't ever develop lung cancer, but now you've stopped them getting heart attacks and strokes and other things they may otherwise have died of. The second study was a smaller study called the Quilt trial, and that was in London. But again, it was a lung cancer population, a screening population, sorry. And in this study, here actually, they did not give the intense treatment to everybody. Patients were randomized to either high intensity treatment or so-called usual care, which is signposting. And again, what was really interesting was they found that about a third of people in the intervention arm quit smoking at 3 months, which is similar to the YES study done in Nottingham. So we know that treatment that's good quality for people in the screening program will mean that a third of them will quit. And it's much better than the 10% who were just signposted who quit. So you triple your quit rates if you provide intense treatment, which is amazing. So I think lung cancer screening has got a huge opportunity to make a difference. And I know that lung cancer screening has been set up all over the country at the moment. And I would say that the single best way of approaching that from the studies, that, as far as we can tell, is having a tobacco dependency advisor there and then when people come to be screened, their CT scan, and being provided with pharmacotherapy and behavioural support. And we know it works.
And I think there's probably a lot of transferable information, isn't there? I think essentially everyone, regardless of where they are, should be offered high intensity opt-out smoking cessation, whether that's in the screening pathway in the clinic, when you're admitted to hospital. I think it's probably something that is not done to the level that we could do it at in any setting at the moment, isn't it? Which is a real shame, but something to learn and to start. I think that perhaps the reframing of it as treatment of tobacco dependency means that it's something that people feel comfortable with, don't they?
That's exactly it. And I would say that, we've talked about screening as a point at which to do it. We've talked about once a diagnosis is made as a point to do it. But I would say the diagnostic phase that we do in lung cancer clinics, for example, or triage clinics is another area. So in Leicester, for example, we refer people on an opt-out basis who are identified as smokers when they're first referred into our service to see as a suspected case of cancer. So that group is therefore people who don't have cancer, but if we identify them as people who smoke, we refer them, and we've got brilliant quit rates. We've got 60% quit rates in those people because they're scared that they might have a lung cancer. So it really works. And ditto, I know that the Manchester team, led by Matt Everson, they have embedded tobacco dependency advisors in their lung cancer clinics. And again, they've had some really good results by doing it on an opt-out basis. So I think it's a really exciting time. We've got some great new drugs. We've got tobacco dependency advisors now embedded in hospitals, and we can really make a difference with our survivorship of people who have a diagnosis of lung cancer or people suspected or at risk of lung cancer. So it's really just a terrific time to be involved with this work.
And it sounds like a positive point to end a podcast on, then some hope. So thank you, Sanjay. Thank you for taking the time and to touch on several important aspects. And I think it's something for us all to take away and perhaps advocate for in our centres so that we can reduce some of this postcode lottery when it comes to accessing treatments for tobacco dependency, but also to reframe it and start to think of it as something that we should be actively treating, not just a lifestyle choice that we sort of passively manage. So thank you for your time, Sanjay.
Brilliant. Thanks very much.
So thank you for listening. We hope that we gave you an insight into treatment of tobacco dependency and lung cancer. For more information on BTOG, including educational events and how to join, you can visit the website at www.btog.org. And please subscribe to the podcasts on whatever platform you listen to your podcasts. Tom and I have quite a few episodes coming in the next few months, and hopefully you'll join in the future.